Okay, welcome to part 2. This is about the applied pathophysiology. So here we're going to be talking about signs and symptoms. And you can see there's a list of some that hopefully you could recite in your... So let's do a quick bit about liver function tests. In either acute or chronic liver disease, there may be an increase in the enzymes involved in amino acid synthesis. In particular, alanine aminotransferase and aspartate aminotransferase, ALT and AST. These enzymes transfer amino groups from one amino acid to another. In this case, we've got alanine and aspartate. So they transfer amino groups from those amino acids, alanine and aspartate. And this process is called transamination. Amination, amino acid, trans, exchanging it. The enzymes GGT, gamma-glutamyl transpeptidase, and alkaline phosphatase, ALP, may also be raised in liver disease, but they're not specific to liver disease. They can be raised in other chronic conditions. So therefore, GGT and ALP are not really specific. ALT and AST, on the other hand, are. So let's talk about right upper quadrant pain, because of course that's where the liver is, that's where the pain is, other than possibly referred pain that we'll talk about in a while. So we need to look at the nociceptors to think about transduction. So we have the mesentery and peritoneal surfaces, and if you remember when we talked about GI before, we pointed out that these are mostly A delta fibers. Because they're A delta, they're myelinated, fast conducting, and therefore the pain is sharp and well localized. And these are mainly chemically stimulated. And our other fiber, of course, was C fibers. C fibers, if you remember, are found in the mucosa and the smooth muscle of the hollow organs. These are unmyelinated, slowly conducting, so we have dull pain that's aching, and it's also poorly localized. And these are mainly mechanosensitive. In terms of the liver, we've also got to think about the phrenic nerve. The phrenic nerve has afferent neurons leading up from the diaphragm. Now, they're thought to be mainly C fibers, and these are primarily responsible for the dull, aching, referred pain to the right shoulder, the ipsilateral, the same side shoulder. So transduction in liver disease, what's going to stimulate these particular nociceptors in this case? So mechanical stimulation through our C fibers could be down to liver and gallbladder distension. It could be edema or stretching of the liver capsule. And this will be detected by TRP channels on these mechanosensitive C fibers. Because they're C fibers, the pain will be dull, aching, and diffuse. Chemical transduction, if the peritoneum becomes inflamed, there may be sharp pain via the chemosensitive TRP channels on A delta fibers. And this may be stimulated by substance P from the C fibers, of course, serotonin, prostaglandins, bradykinin, etc., the chemicals. In terms of the liver, this seems less likely, because in liver disease we don't really get a rip-roaring peritonitis, for example. Which brings us to transmission. So action potentials are conducted up via the vagal and the spinal primary afferent neurons up to the dorsal horn, where of course they then synapse with second order afferents. The second order afferents ascend via the contralateral spinothalamic and spino-reticular tracts to the thalamus. Here they synapse with third order afferent neurons or tertiary neurons, which then travel up tracts within the brain to the somatosensory cortex, to the relevant area, depending on where the pain's coming from. We also have branches going off to the hypothalamus and the limbic system. The one to the hypothalamus stimulates the autonomic nervous system. So we end up getting a sympathetic reaction. This sympathetic reaction in any pain of sufficient severity that's going to do various systemic things. And we know what the sympathetic nervous system does. It increases heart rate, increases blood pressure, causes sweating, causes peripheral vasoconstriction, so we get pallor. So these are all common symptoms that we see alongside severe pain. Referred pain is down to those phrenic afferents from the diaphragm primarily. And in any referred pain, if you remember, what we have is we have two sensory afferents, one generally from the skin, one from an organ, that share a second order afferent at the same spinal nerve level, also known as a dermatome. The brain, of course, will then tend to perceive the pain as coming from the skin rather than the organ. In terms of the liver, as we said, or the gallbladder, it can stimulate the phrenic afferents of the diaphragm. These then share a second order afferent with the skin of the right shoulder. Neurogenic inflammation is a possibility because we may be getting secreted neurokinin such as substance P, and this could then cause both peripheral and central sensitization in acute conditions, and in more chronic longer-term conditions it may even stimulate long-term potentiation of all those synapses in the sensory pathway. So let's have a look at signs and symptoms in relation to the stage, in relation to that progression that we talked about in the last video. At the steatosis stage, it may be completely asymptomatic. There may be some nausea, vomiting, anorexia, abdominal pain, some sort of undefined mild symptoms. Because the liver is the hepatocytes getting quite fatty, there may be a little bit of hepatomegaly. Once we get into steatohepatitis, we start seeing more defined symptoms. Things like asthenia, which is weakness of the muscles and loss of strength. Possibly weight loss, fever, hepatomegaly, because of course we've got inflammation going on now as well with edema and everything else. So the liver will enlarge. It also may be tender on palpation. We may at this stage get some jaundice, some itching, pruritus, and possibly start to see the outcomes of malabsorption. So we may get some malnutrition, particularly of various vitamins like folate, B6, thiamine, and vitamin A. Which brings us on to cirrhosis. Here we start to see some more significant signs and symptoms. There may be hepatomegaly The liver might even shrink slightly, however, but it will be nodular. On palpation, it will feel nodular. Because of back pressure from hepatic portal hypertension, it will have an impact on other areas of the abdomen, other organs. So there may be splenomegaly, there may be renal impairment, and there may be ascites. There may be esophageal varices, and we'll talk about the collaterals that cause these. There may be jaundice. Other things you might see, palmar erythema, that you always check for in OSCEs. There may be spider angioma, or there may be caput medusae. Caput medusae are a bit like esophageal varices, but you see them on the abdomen, around the umbilicus. There may also, in the final stages, be degrees of encephalopathy. This could be liver flap, asterixis, that again you always look for in OSCEs. There may be a mild degree to a more severe degree of loss of memory and concentration, insomnia and irritability, and possibly in the final stages hallucinations and convulsions. And I have nursed someone at this stage, and it was really quite traumatic and sad to see. Anorexia, nausea, vomiting, malaise and aches can sometimes happen early on in early hepatitis, particularly in HCV infection, where there may be a flu-like period due to the acute inflammatory process and the innate immune response. In terms of the nausea and vomiting, it's not really very clear what's causing that. But interleukin-1, which causes one of our key inflammatory mediators, one of our cytokines, has been linked to stimulating nausea when given intravenously. Fever. Fever is going to be caused by what, do you think? Exogenous pyrogens. So in this case, we could have HCV. HCV would be an exogenous pyrogen, or parts of it, but also endogenous pyrogens. Bearing in mind we have steatohepatitis, we have an inflammatory response. So we are going to release our usual pyrogens that will then go and bind on the blood side of the blood-brain barrier and stimulate the release of PGE2 on the hypothalamic side, which binds to EPR3 receptors, etc., raises the set point. So prostaglandin E2 is stimulated by either exogenous or endogenous pyrogens to raise the set point in the hypothalamus. To have a review of how inflammation and the release of cytokines can stimulate all of these things, please have a look at the Unwell Person handout. And again, within that handout, you will see information about how inflammation can cause muscle weakness, asthenia, can cause weight loss, and also malnutrition with loss of appetite and all those effects. In addition, in particular in liver disease, there may of course be malnutrition because of those issues we talked about, the loss of the fenestrations in the endothelium of the sinusoids, the loss of the permeability of the basement membrane, the loss of hepatic microvilli to ensure there's a good area for absorption, and also the build-up of collagen within the space of discs and around the hepatocytes This all potentially causes the malabsorption of those enteric solutes, those nutrients sent to the sinusoids by the portal system. And of course there's hepatocyte dysfunction, and a lot of the roles of hepatocytes is to metabolize carbohydrate, proteins, fats that we take in, and then put them into a usable form or store them. If the hepatocytes are dysfunctional or they've gone into apoptosis, necrosis, then we are going to have a reduced ability to do that. So we're going to get reductions in the storage, activation and transport of many vitamins and minerals, plus the carbohydrates, proteins and fats. And that is going to cause widespread malnutrition. We may also have anemia because, of course, if you remember, the liver also metabolizes and stores iron, which of course is needed for erythrocytes, but also those B vitamins, B12 and B9, that are needed for the synthesis of the DNA of the erythrocytes. And this may cause anemia. Hepatomegaly. Of course, as we've said, if you've got steatohepatitis, there's inflammation. And in any inflammation, you remember your cardinal signs, there will be edema, there will be immune cell infiltration, there will be exudation. All of this will increase the size of the liver in the early stages, at the steatohepatitis stage. In chronic stages, we've now got hepatocytes full of fat, we've got necrosis, cellular proliferation, because we're now getting into that chronic morphology of inflammation, where we've got tissue damage in association with tissue repair. So cellular proliferation is going to add to the size on top of the inflammation. Fibrosis. Fibrosis is going to start to give the liver a firmer feel. So in this case, in the later stages, particularly in fibrosis, you're going to get a firmer but still enlarged liver. Later on, when we get into cirrhosis, the liver becomes harder because, of course, we've got all that collagen being laid down. It may become shrunken, and it's certainly going to become nodular due to the septa and those regenerative nodules. Androstenedione is the precursor of testosterone and estrogens. Its clearance is decreased because of hepatic failure. What this results in is an increase in circulating estrogens and a raised estradiol to testosterone ratio. And estradiol is the main endogenous estrogen. So we've got more estrogen compared to the amount of testosterone. And this causes a few funky things. One of them is your palmar erythema. It's thought to be due to estrogen-stimulated increase in the density of the capillaries in the palms of the hands. And this is really based on the known effect of estrogens in terms of the endometrium. It increases the capillary density. So the theory is, don't ask me why in the hands, it does it in the hands. Spider angiomas or nevi, the theory is that this is also linked to this. There's a combination of vascular growth factors because of inflammation, And we've got this increase in estrogens, which stimulate vasodilation and neovascularization. So you end up with these little skin lesions that look like little red spiders. Gynecomastia is fairly obvious, really, if you think about it. If we're increasing the circulation of estrogens compared to our testosterones, it's going to cause the proliferation of breast tissue, because breast tissue is stimulated by estrogens and inhibited by testosterone. Alongside this, poor men may also get testicular atrophy. So there's our palmar erythema. So this is estrogen stimulated increase in the capillaries in the palms of the hand. Spider nevi due to vasodilation and neovascularization. And this is a combination of the raised estrogens and also the presence of growth factors. And gynecomastia. We have this proliferation of breast tissue due to these increased estrogens and possibly testicular atrophy, but I'm not putting that picture up. Which brings us on to our classic signs of jaundice, which we have to link in with dark urine and pale stools. So we've got yellowing of the skin, darker urine, but pale stools. Now, heme, if you remember heme, we've always said when it's oxygenated, then it's bright red. When it's not oxygenated, it's brown. When senescent erythrocytes start to die off, the heme is broken down. When it's broken down, it becomes bilirubin. Bilirubin is transported to the liver then in an unconjugated, which means it's not water-soluble state, and it's bound to albumin. So we have unconjugated bilirubin and albumin carried off to the hepatocytes. In normal circumstances, what the hepatocytes do, they conjugate the bilirubin, in other words, they make it water soluble so that we can then excrete it. The conjugated bilirubin is then excreted in the bile to the duodenum via the gallbladder. And of course, eventually it's going to move through and come out the other end. A certain amount of that, though, 10% of it, is then converted to urobilinogen in the GI tract. This then goes back through the hepatic portal system, reabsorbed by the hepatocytes. The hepatocytes then excrete that via the kidneys in urine. And this is what gives urine its usual colour. The conjugated bilirubin in the stools, remember heme was brown, is what gives stools their dark colour. So conjugated bilirubin gives stools their characteristic brown colour and urine its straw colour. But, of course, you can see, I'm sure you've already anticipated a bit of a problem here, because in liver disease, the hepatocytes either can't take up the bilirubin, or they can't conjugate the bilirubin, so it becomes water soluble and we can get rid of it, or they can't excrete the bilirubin, or a combination of all. Depending on which, there may be high levels of circulating either unconjugated or conjugated bilirubin. High levels of unconjugated if the hepatocytes haven't been able to conjugate it. If they've conjugated it but not been able to get rid of it, then it's going to be conjugated bilirubin circulating. This excess circulating bilirubin then gets lodged in the tissues. And this is what makes the conjunctiva, because it's a highly vascular area, and also the dermis appear yellow. And this is where we get jaundice. Of course, if we've got excess circulating conjugated bilirubin, that's going to increase its excretion via the kidneys through glomerular filtration, and it's going to darken the urine. So whereas the urine was a nice straw colour with a small amount of it, a large amount of it is going to make the urine look much browner. And in terms of the stools, of course, they're going to be pale, because if conjugated bilirubin is not excreted via bile, through the gallbladder, off to the duodenum, into the GI tract, then the stools are going to be very pale without that brown colour from the bilirubin. Pruritus is often associated with jaundice, but it's not really got an awful lot to do with it. It's thought to be due to retained bile salts, and it occurs particularly if there's any obstruction of the biliary tract. So, of course, you could have gallstones, but you could also have a very inflamed liver. This stimulates histamine release. Now, histamine is known to cause itching. You think of allergic reactions, urticaria. So histamine binds and stimulates puriceptors, itch receptors. And as I said, there is no direct correlation with bilirubin. Although we always associate jaundice and pruritus together, there is no pathophysiological link between them. Which brings us on to the biggie, portal hypertension. Portal hypertension, you can imagine, has loads of knock-on effects in terms of the abdominal organs and the abdominal cavity. And all it takes, if you think of all the sinusoids running into all the lobules, all it takes is a tiny reduction in the width of that lumen in all of those sinusoids to give an awful lot of resistance and an awful lot of backward failure, a bit like in our heart failure, backward pressure in terms of the hepatic portal veins. This, of course, is then going to impact on the organs within the abdominal cavity. In liver disease, we get, in addition to any other cause, we also get vasoconstriction of the sinusoids. Part of this is because there's an overexpression by sinusoidal endothelial cells of a vasoconstrictor known as endothelin-1. And it's thought that this is probably stimulated by vascular endothelial growth factor. RAS and the sympathetic nervous system are stimulated because you start to get a reduced systemic blood volume. It's all being held up by the liver, it's not returning to the heart, so we've got a bit of a blockage in the system. That blood volume drops, it's picked up on glomerular filtration by our juxtaglomerular cells who activate RAS. RAS recruits, of course, the sympathetic nervous system as well, which can also be recruited by the baroreceptors. Another thing that might stimulate this is because we've got portal hypertension, this is going to put backward pressure on those capillary beds of the organs, on the splanchnic beds. When that happens, we're going to get a release of local vasodilators like nitric oxide. So within the splanchnic beds, there's going to be vasodilation. So that's going to hold a lot of blood there that's not going to be returning to the kidneys, and that's going to reduce blood volume too, systemic blood volume. Of course, once stimulated, angiotensin II and noradrenaline cause systemic vasoconstriction to compensate for this drop in blood volume and blood pressure. That vasoconstriction is also going to affect the sinusoids. The sinusoids, okay, they could release nitric oxide. They're lined with endothelial cells. Endothelial cells secrete nitric oxide when there's an increase in pressure. But the problem is this is actually reduced because we have these damaged or dysfunctional sinusoidal endothelial cells. So therefore we have vasoconstriction of the sinusoids. This vasoconstriction of the sinusoids, in addition to any other factors, is going to increase resistance. It's going to add to the problem of getting blood flow through the liver and back to the heart. Other factors that add to all of this as well, of course, we've got hepatocyte enlargement. That hepatocyte enlargement is going to reduce the sinusoidal lumen further. We've got the fibrosis, we've got collagen in the space of dis. That reduces the elasticity of the sinusoidal wall. So even if we wanted to vasodilate, that collagen there would potentially stop it happening. In later stages, we got regenerative nodules. So it's possible that these regenerative nodules would actually compress some of the venules, either running in to the liver or compress the sinusoids. And of course, we've got edema, we've got fibrosis and necrosis. Remember those hepatic stellate cells, when they became myofibroblasts, also tend to migrate. So if they start laying down fibrin collagen in the sinusoids themselves, then they're going to cause an obstruction. The whole liver may be inflamed, which is also going to decrease the size of the lumen. Another problem we have, so this is about outflow that we've been talking about, this vasoconstriction of the sinusoids, the mechanical obstruction of the sinusoids, is all going to reduce the outflow of venous blood arriving at the liver via the hepatic portal system. But we've got an additional problem. There is the potential for the arterial blood flowing to the liver to be increased. So we have various things that could potentially vasodilate the arteries supplying the liver. This could be inflammatory mediators, it could be local nitric oxide, all trying to reduce the resistance, and also possibly reduce noradrenaline sensitivity. Remember, we talked about decompensation in heart failure. If you release too much noradrenaline, often what happens is cells will take down some of their adrenoreceptors to reduce the sensitivity to this excess noradrenaline. Another problem is something we'll talk about in a minute, is the formation of collaterals. This may also increase arterial flow. And again, you remember when we talked about collaterals in terms of angina, the the coronary arteries can form new vessels that will join up, and they will bypass an area that is a potential problem. And this is what happens in terms of all these circulatory problems caused by liver disease. So we have increased arterial flow, and of course that's going to add to sinusoid congestion and resistance, because this is another lot of blood that we're trying to get through those narrowed sinusoids. So we have reduced portal venous flow, outflow, due to resistance within the liver, and we have increased arterial flow, inflow, leading to hypertension in the portal circulation. Which brings us to our collaterals. Esophageal varices are one outcome of the formation of these collaterals. So what happens is, over time, collaterals develop, and this is an attempt to divert the portal venous flow back into the systemic circulation. In other words, it's trying to move the blood around the liver and avoid the liver. Of course, that's not going to help in terms of malabsorption, because the blood's bypassing the liver. We can't metabolize those enteric solutes and use them. So it's not a great solution, but it happens. It's called portosystemic shunting. And in terms of esophageal varices, this is a gastroesophageal collateral that is a common development of this portosystemic shunting. And it gives these varicose veins in the esophagus, the esophageal varices. Another outcome of this is when there's an umbilical collateral develops. And this is where we get caput medusae. I assume it's named after Medusa. These collaterals can be seen on the surface of the abdomen radiating from the umbilicus. And as we said, by diverting the enteric venous flow away from the liver, it's going to contribute to malabsorption and malnutrition. It's also going to mean that we've taken that secondary filter out of the blood coming from the GI tract. So remember, we said any pathogens that manage to make it through were going to get nabbed by the Kupffer cells in the liver. Well, that's not going to happen if you bypass the liver. So we have potential for malnutrition, even more, and the risk of systemic bacteremia and toxemia. So let's have a look at the abdominal cavity and what happens as a result of this portal hypertension. Portal hypertension, of course, creates this pressure in the splanchnic beds, in the capillaries of the abdominal organs. They release nitric oxide from their endothelial cells, and remember, nitric oxide works locally, and the capillaries of the splanchnic beds are stimulated to vasodilate. This vasodilation, if you combine it with forward resistance, because the blood can't get into the portal vein and because it can't get through the liver, may end up causing some transudation into the surrounding interstitial spaces. This vasodilation, of course, as we said, can reduce systemic blood volume and triggers RAS. And also this transudation, of course, is taking water out of the blood, so that also reduces blood volume. As we said, this activates RAS via the juxtaglomerular apparatus because glomerular filtration goes down. Of course, if we activate RAS increases the blood volume. Angiotensin II, its mates aldosterone, ADH, all increase blood volume by increasing the reabsorption of sodium and water within the renal tubules. This is going to give us an additional problem because the increased blood volume increases the hydrostatic pressure in the sinusoids and also in the splanchnic beds, in the capillary beds of the organs. This increased hydrostatic pressure is going to cause more transudation. Fluid, again, is pushed into the interstitial space. Now, up until a certain point, the lymphatic system can cope with this. It takes it away, carries it away. But if it becomes overloaded, it spills over into the peritoneal cavity. So we end up with a peritoneal cavity full of transudate. And this causes ascites. Another problem is that the reduced renal blood flow will reduce glomerular filtration rate. Pressure, natriuresis, remember that? And this tends to happen in the late stage of cirrhosis with ascites. The spleen may also become enlarged because we've got increased back pressure in the splenic vein. It can't empty out because there's a hold up in the whole hepatic portal system. So we get increased pressure there. The spleen suffers also from transudation and it enlarges. When it enlarges, it traps platelets and leukocytes. Remember, the spleen is a bit like a filter for the blood. It traps the platelets and leukocytes. It also increases the breakdown of erythrocytes. And this is going to cause thrombocytopenia, leukopenia, and or anemia. So the level of platelets is going to go down, the level of leukocytes is going to go down, and potentially the number of erythrocytes. So all of these we've got now in a reduced immune ability, we've got reduced clotting ability, and we've got anemia. So let's have a look at that in a diagram. So we have vasoconstriction and obstruction in the liver. We also have increased arterial inflow alongside that decreased outflow. This gives us portal vein hypertension. We've got congestion in the liver, we're going to get back pressure, a bit like our backward failure in terms of heart failure. We may get portosystemic shunting. Remember, this is the formation of the collaterals to bypass the liver. We get vasodilation in the splanchnic beds, in the beds of the organs of the abdomen. We also may get reduced glomerular filtration rate and RAS activated. That's going to have an impact on all of these different systems. As a result, we have transudation from the organs within the abdomen. And the spleen may become enlarged because its outflow is being restricted. So that was hepatic portal hypertension. As you can see, there were a lot of knock-on effects there in terms of the abdominal organs. Hepatic encephalopathy is where we start to get a problem with chemicals that impact on the central nervous system rather than the abdominal cavity. So hepatic encephalopathy can vary, as we said, from a lack of alertness to full-blown coma or convulsions. It potentially includes the signs of liver flat, asterixis, loss of memory, poor concentration, insomnia, irritability, right up to hallucinations, convulsions, and coma as later signs. The theory is that encephalopathy in this case is due to the effect of ammonia and neurosteroids on the levels of GABA in the brain. And there is some recent research that is trying to implicate the microbiota of the gut in stimulating ammonia production in addition. Ammonia itself is a byproduct of protein degradation and also the deamination of amino acids, in other words, the taking off of the amino group. This happens normally due to bacteria in the intestine. So you can see where the link comes in with this microbiota influence. Now, ammonia in a normal physiological healthy situation is usually converted by the hepatocytes and then excreted as urea in the urine. This is where urea comes from. But, of course, you can see where we're going here. We've got liver failure. So, just like our bilirubin, ammonia is not converted due to hepatocyte dysfunction or due to portosystemic shunting bypassing the liver, those collaterals going round the liver. So it ends up circulating in the blood. If we have reduced glomerular filtration, this is also going to contribute to the retention of ammonia, which increases it even further. Now, ammonia is a neurotoxin, and we're not going to go into the full details of how it does it. You don't need to know that. But what it does, it alters GABA signaling in opposite ways. So GABA levels can either go up or can go down at different stages of encephalopathy. Because we have a complex interaction of multiple factors, it's not straightforward to say it puts it up or it puts it down. It does different things at different times. But we are going to get variation that we don't need in the levels of GABA signaling. Ammonia also causes cerebral edema through the process of creating an osmotic gradient. It impacts on astrocytes. Remember the importance of astrocytes in the brain in determining the levels of neurotransmitters at synapses. So via interaction with astrocytes, ammonia then upregulates neurosteroids, endogenous neurosteroids. Now, neurosteroids are normally synthesized from circulating steroid hormones. What they actually do is they sensitize GABA receptors. GABA is an inhibitory in the CNS neurotransmitter. So this is going to cause IPSP upregulation, the increase of inhibitory post-synaptic potentials. So this is going to depress CNS function, depress brain function. And this is going to reduce neuronal excitability within the brain. Asterixis, your liver flap, and this is the proper way to test it, is linked to encephalopathy. And it's thought to be that this all happens in the thalamus. Remember, the thalamus is the precortical relay point. Ammonia and the neurotoxins alter synaptic transmission, which has an impact on the balance between the agonist and the antagonist muscles needed to maintain position. Remember way back when we talked about the cross extensor reflex, we talked about reflexes, and we said that obviously the muscle that's contracting needs to be stimulated, but we need to inhibit the antagonistic muscle to cause it to relax. And this is impacting on our ability to do that, and for some reason it gives us this bizarre phenomenon of asterixis. Which brings us to the end of our hepatic session. And yes, cheers. I don't know what that has done to your desire for a drink now, but yeah. Anyway, there are a couple of articles for you in the Moodle section. One's on LFTs. The other one is more optional. This is about nutrition and the role of the liver. If that's your particular clinical area, then you may need to have a look at that. As usual, do all your note making, your study buddies, your diagrams, and try and learn this topic before we move on to our final topic, which is all going to be about headache. Don't delay getting all of this under your belt. As I said, I'm going to count you down now because the exam is only 7 weeks away. I know you've got Christmas in the way, but you might have plans for Christmas.